A very good morning, everyone, and thank you for the organizers. This is such a pleasure. On a Sunday morning, I'm quite happy to see that the hall is relatively full. So congratulations and thank you. So I don't feel very lonely. Can I have the opening slide, please? Okay, so I am going to start with this. Prof Chin told a story from East Malaysia. And many of us, we are well aware that East Malaysia is geographically very pretty, very beautiful, but also it results in a lot of isolation for patients. But this is Aisha now. Okay, so Aisha is 38 years old. She's from Bhoo, Kelantan. She's a single mother of 2 school-going kids, and she works in a local timber factory, right? And I've got a long story for Aisha, which is why I had to print it out. So last year, Aisha was diagnosed with breast cancer. Her doctors told her she was lucky because the disease is curable. Her treatment would be free at the public hospital. So this is good news, right? So many of us in the health systems, we say your treatment is free, congratulations. So congratulations to Aisha. So she had a mastectomy to remove her breast. Her doctors suggested breast reconstruction, but that was not available in the public hospital. She was referred to a private hospital, but she declined. Not because she didn't want to, she couldn't afford the surgery, not just in monetary terms, but also the downtime. She also needed physiotherapy. Again, she declined because she had to take leave from work. Radiotherapy, she couldn't say no. The doctors say you will die. Even after mastectomy, she needed the radiotherapy, said if you don't take the radiotherapy, you might die. So she had to agree. So she traveled hours every week to get it. The treatment is free, right? But every trip cost her something. A day of unpaid leave, long distance bus fares, finding someone to watch the kids, and the quiet fear that her boss is going to lose patients. So this is not a made up story. It is a story of many patients. Not Aisha, but it can be another person, a man, can be another part of Malaysia. So going back to Aisha, she had a small insurance policy, private health insurance policy. It does not cover reconstruction surgery. And even the physiotherapy that's available within Bhoo in a private facility is also not covered under the insurance policy. She couldn't afford a proper breast prosthesis, so she just stuffs a piece of cloth in her bra when she go to work. There's no place to rest at work. We have already heard Dr. Gogilan said something about occupation, right? So on very bad days, she just stays at home because she have no place to rest at work anyway. So she loses income. Some nights, she wonders if surviving cancer will cost her everything else. Her doctors say she's fortunate, but Aisha does not feel lucky. She's not just surviving cancer, she's surviving everything around it. Okay, so I'll stop reading now. So this is the background that I'm going to start with. Can I have the next slide, please? I'm able to control myself, right? Yeah, okay. So what covered doesn't cover. So we were talking about a lot of free things, right, in Malaysia. I know not everything is free, but even if things are free, I'm here to say that there are things which are not covered. So we have a whole list of things which is listed here that covered doesn't cover. In Malaysia, in mature health systems, in high income countries, with the best financing possible. These are things that often is not covered. So on top is travel. So I'll stop here because I'm going to focus on travel. But this is just a list. If you see there, complex system to obtain financial support. So things are available but not accessible. I think these are important concepts that we must remember. So how much must Malaysians with cancer care travel to get pain relief? This is a study that we did a few years ago. This is a study which was simply done, no patients involved. All we did is we found a list of centers offering pain relief or palliative care all over Malaysia. And we took every district, we plotted the distance on Google Map from every district to the nearest palliative care. So the palliative care can be hospital-based, can be very simple, but basically we want to look at what kind of access supportive care or palliative care that patients receive, and you look at the dots. I don't have to say anything, right? So all of us kind of predict that yes, in East Malaysia it's very sparse. So yes, that's what we found. So you see the number of dots, and you see, so some may argue that, yeah, but we also must look at the population density. Even with accounting for that, don't you think this is a bit unfair? It's unfair, right? Not a bit, it's a lot unfair. And if you look at the East Coast, also the same. Look at Terengganu. You have 2 dots. Pahang got 4 dots. So you see that there is over-representation in some states and under-representation or underdevelopment in services in some other states. And we are a country that we have been very proud to say that we are making good progress, if not have reached universal health coverage. So this is the problem. So how much do they spend? Okay, so overall in Malaysia, to get pain care, people have to travel, anyone, any disease. It's not specific to cancer, because this study was not focused on people, it was focused on facilities. So they have to travel a median of 40 kilometers overall. But if you look at the different regions, in central region, like in Klang Valley, it's about less than 4 kilometers. In East Coast, they have to travel 45 kilometers one way to get pain relief. And in East Malaysia, it's 82 kilometers. And if we translate that to the time taken, overall in Malaysia is 60 minutes or 1 hour. And in central region is 15 minutes. In East Coast is 70 to 80 minutes, and East Malaysia is almost 2 hours to get pain relief, right? And if you look at the time, it also depends on whether one takes public transport or they drive their car. If they take public transport, it's a lot more time. And a lot more time is not only for the patient's convenience, or inconvenience, or the family member's inconvenience, but it also means that somebody is losing wages somewhere along the line. Wages, and they also have a lot of costs that I wanted to talk about today. So this is for pain relief. So why should we be concerned about travel burden? Because sometimes we tend to forget, right? We are very focused on providing the best care, making sure we have all the state-of-the-art diagnostic and therapeutic services for our patients and their families. But we forget that even coming to the hospital is often a problem. And even if you are in a high income setting, you will have pockets of populations who will not be able to access. And if we forget that, we are missing the bigger picture. And the very core concept of universal health coverage is being fair, not being equal, being fair. So from an equity lens, travel burden is a growing health-related social need. This health-related social need, if you look at the space of social determinants of health, is very much connected. It's a relatively new term that we coined to say that there are many other social needs which are tied to health. And we need to be cognizant to the fact that this can be a problem if we choose not to look at it. And for cancer patients especially, it's a repeated unavoidable cost due to the intensity of care. If it's a radiotherapy, it's going to be more. If patients are going to be on long-term therapy, it's going to be more, and things like that that people can't avoid. And who's most affected are people from the rural areas, lower income households, or even marginalized populations within cities. So this includes, like women, elderly, even can be children. So because there are fewer nearby cancer centers, there's limited affordable transport, there is difficulty self-transporting, which means that you have to depend on public transport, which is not reliable. So these are a few excerpts from a whole series of qualitative studies that we have been doing in Malaysia. Free still comes with a cost, that's a core theme. So one of it, our patients say treatment in public hospitals is free, but there are many other costs we have to bear. So what you're trying to imply is we don't often ask about the cost or think about the cost. Prof Chin said it very nicely with his own real example, right? We are very excited and say, hey, this is free, come. But we don't know, and we get angry when patients don't come. I think that's even worse. I think like 10 years ago or even 20 years ago when I was practicing, I get upset when patients don't turn up. I was not treating cancer patients, but I was treating patients with diabetes, for instance. And I get angry with them, not knowing all this, very naive, and also I think very patronizing, I think. So we need to change the mindset that we have. And barriers to ongoing care, so not only cost, there's a cost, you have to borrow from people to come to the hospital. So sometimes patients don't turn up at your doorstep because of some things that you think, what kind of excuse is this? I think many of us are guilty of that. Physical and emotional toll, so even because of the long nature of the travel, even and given with all the therapies that people get, it can be very tiring emotionally and physically. So these are things that many doctors, healthcare professionals miss. So what we studied, I'm going to give a very brief thing because this is going to come up soon, is watch out for the space. So we looked at 1,200 Malaysians who were diagnosed between 2021 and 2022 with cancer. We focused on 6 public hospitals, also did an NGO outreach to make sure that we have patients from everywhere, also from East Malaysia, from East Coast. And what we measured was the number of trips these patients with cancer did in the last 4 weeks, two-way distance, the time, and the out-of-pocket travel cost. And what we found, so it's again going back to region, right? In Central Peninsula, the median distance that people had to travel for cancer care was 72 kilometers and took about 2 hours. In non-Central Peninsula, meaning East Coast Malaysia as well as East Malaysia, the median distance, is 370 kilometers to and fro. And the distance is about 3 hours. For East Malaysia, it's 100 kilometers and about 2 hours. 3 hours, actually that is 6 hours, sorry. So it's very long. And the shocking thing that we all thought that we're going to get a gradient and East Malaysia is going to be worse, but it's actually not East Coast Malaysia, Kelantan, Terengganu, and so there's a lot of disparity even within Peninsular Malaysia. So rural patients travel 5 times longer. And what else we found is that they also So we also calculated costs. So 1 in 5 households with cancer spend more than 10% of their total monthly household income. So this is a total income. From the family's total income, 10% was spent on travel. That's a lot. You are not talking about the disease, you're not talking about the food bills, the children's bills, everything else. If families are spending 10%, we are actually looking at people really going in trouble very quickly, right? And again, there's a lot of disparity by region, but also by income group. So for low income groups, on the whole, 5% of families spend more than 10% of the monthly income for travel, for cancer. But when you look at the people who have spent more than 10%, right, you also see a lot of disparities. In high income, so when we talk about a lot of patients, we tend to think that, okay, travel cannot be a problem for even middle income. It's a problem of B40. Not true, right? There is a 5%, but you look at that. So there are a lot of our assumptions are incorrect. And we need to pay a lot of attention to how travel affects people. So, and any policies that we make, if you're very hospital-centric and thinking only about providing things but not about how accessing things are also challenging, we are missing the big picture. And also, we did multivariable analysis and connected how patients who spend for travel, what is the impact on the overall financial well-being of the family, as well as their own quality of life. So higher travel costs was associated with higher financial toxicity. That means distress for the family because of all the cost-related concerns that they were having in relation to cancer. And also the longer travel time and distance and the higher travel cost was also associated with lower quality of life. So this is empirical evidence. Usually we say, oh, maybe it's related, possibly it's related. It's not maybe, it's not possibly, yes, it is related. So we have real data, and I think one of the things that you have to remember is, yes, people from East Coast are affected, but so are people from East Coast Malaysia. And the worst groups who are really impacted are the low-income families, as well as the middle-income families. So, with what we have, we know. So this is a summary of what we find. I think I already said it even before. So, a lot of things I've said that I'm going to skip to the next. Okay, so I think one of the things, because there are a lot of young people here, so I wanted to put this especially in front of you. The message is we cannot fix what we do not count, right? So either you want to do it as a research, or do you want to do it as a part of your service? When you see patients, when you're clerking patients, do you want to ask them about how long they travel? I think we should, so that you don't end up being angry, so that your management is tailored according to how far they live. I think it's not far-fetched. Long time ago, we would think that that's too much, you know, like I can't deal with it. My job is a physician. I'm only going to treat, you know, like this is social worker's job. I don't think so, not anymore, right? So the key aspects that we want to be captured is what is the travel time and distance, what's the mode of transport, how much do they spend out of pocket, what is the frequency of visits, that's something that probably you can already extract from your treatment plan, and the emotional impact. And all these can be done in a simple patient-reported questionnaire. We have done it. It doesn't take long. So it can be part of, and they can even fill it up themselves. So I think this is something that we should be doing. And, okay, so policy reflections. I said a lot of things, but I think one of the key things is, of course, what I said earlier. We need to measure. Only when we measure, we know. But there are simple things, I wouldn't say simple things, but if we weigh against the cost of a lot of other things, we can do this. It's just that we need a lot of political will. One of it is to decentralize supportive and palliative care services. We have a lot of NGOs, but I think depending purely on NGOs does not work. It's not sustainable. So we need a government level, policy level, top-down approach where we stress on how there needs to be allocation of budgets, fiscal support for decentralization. And that is especially important in East Coast and East Malaysia. And fixed financial protection schemes that we have. We have them. There's a lot of bureaucracy. I have a whole lot of data on how patients complain about bureaucracy. They are too much of paperwork. They just can't deal with it. And sometimes things get rejected, or sometimes people don't know. So we have to fix it. And I think the other good news is, because it's health-related social need, it's not only the health systems that can help. There are many, many other systems that can help, many sectors, public, private, but also help beyond health sectors. So, you know, like transportation, welfare, and so on. So we are not talking enough to each other. So I think we need to start talking to each other, and not only talking to each other, but work out solutions. It can be done. Again, political will, you know, like everybody must come together. And sometimes the health system feels that this is too much for me. But I think it shouldn't be. We should be the convener of such efforts. And I think travel burden must be integrated into national planning. So we all know it. We have a lot of requests on more cancer centers, which is well justified with this sort of data. But it's not just cancer centers, right? So we need to make sure that in order for all this to happen, it needs to go into our policy documents, so that a lot of funding, or at least a part of the funding, can be focused on this stuff. So with that, I'm going to stop. Thank you very much. And